right, hello and welcome to the Spinal Cord Injury Forum. I'm Chuck Bombardier. I'm a psychologist and professor in the Department of Rehabilitation Medicine here at the University of Washington. Tonight I'm very pleased to welcome Dr. Jelena Svircev. She's one of the staff physicians at the Spinal Cord Injury Service in the Department of Veteran Affairs at the Puget Sound Health Care System. And she's also an associate professor in the UW Department of Rehabilitation Medicine. Tonight, Dr. Svircev is going to talk about the challenges that people with spinal cord injury face when they are seeking medical care or healthcare providers, including how to decide what kinds of providers they need to see in different situations, and also about how to educate providers who are not SCI experts, how to educate them about your SCI issues. After Dr. Svircev's presentation, we'll take some questions from the audience. But for now, please join me in welcoming Dr. Svircev.
Well, thank you. Thank you, everyone, for making time to come this evening. This topic is slightly less well-defined than I think some other SCI forum sessions, but I'm hopeful that it will be quite engaging, particularly with some of your input. So how did this topic come about? This topic came about when I threw out to the team here an idea of how neat it would be to get together a group of individuals to talk about some of the great things, some of the kooky things, some of the painful things that providers have told folks with spinal cord injuries, and how individuals with spinal cord injuries responded in that moment of, oh, that felt really good. I felt very supportive of, oh boy, that was kind of really awkward. How do I tell that provider that that wasn't quite so great? In looking back at some of the topics that were offered at the SCI Forum, we saw that a few years back, in 2016, a topic had been covered on discussing primary care for folks with spinal cord injury, and this was really delivered from the primary care provider's perspective. The following year, there was a discussion that many of you individuals perhaps were involved with, talking about the consumer perspective. So what do SCI professionals like myself need to know from you? So we thought we'd kind of take it a little bit of a different slant of what do and how do people with spinal cord injuries talk to their non-SCI providers about some of their needs and kind of some of the things that I've seen in the SCI physician's perspective. So this presentation is going to be divided into kind of 3 sections. They may seem a bit separated, but at the end of the presentation, you'll kind of see how they all came together. So a few objectives that we have for the presentation. I'm hoping that we can all, in the end, figure out, kind of determine and align our symptoms and medical conditions with the most appropriate medical setting at that time. I'm hoping that I can offer you some communication strategies to effectively share your knowledge with non-SCI providers. And I'm hoping that all of us will be able to go home with at least one resource that they can, with confidence, offer a non-SCI provider for somewhere they can go to about, for information on SCI issues. So when we take a look at healthcare utilization by individuals with spinal cord injuries, we see that there is some data out there. So when looking at that first year after injury, we see that in that first year, over 85% of individuals with spinal cord injuries will be meeting with a primary care provider. Over half of those individuals are going to visit the emergency room for some reason. Nearly half of the individuals are going to be hospitalized for some reason. And a quarter of individuals will require surgical intervention. We see that individuals with higher level injuries and more neurologically complete injuries access the healthcare services more often. We see when we take a look at the hospitalization reasons that the most common reason for rehospitalization are genitourinary causes, so bladder or kidney related, or respiratory conditions, lung related, things like bronchitis and pneumonia. And the most common reason for emergency room visits or urgent care visits are once again genitourinary reasons, those bladder reasons, or musculoskeletal reasons, so muscle pains, strains, or fractures. When we look at the time after the first year of injury, we see that the number of encounters that patients have with providers decreases, but it still remains higher than that of the non-SCI population. We also see that much of the care transitions away from the specialist, so moves away from rehab doctors and SCI doctors and more towards family practice physicians or internal medicine physicians. But we also have to appreciate that family practice physicians, while they are going to be seeing folks with spinal cord injury quite often, they might not be as familiar with the lifetime needs of folks with spinal cord injury. So we've got a knowledge gap there. Barriers to healthcare, as many of you can appreciate, can be both physical and non-physical. Legislation mandates can insist on the physical resources be available to individuals with spinal cord injuries or those folks who use chairs or different accessibility devices. But we know that enforcement of those regulations can often be slow, and there's really inconsistent application of some of those principles. So many of you are very familiar with the accessible, non-accessible bathrooms, or the accessible, non-accessible exam rooms where you are able to roll into the room and roll out, but there is no lift to assist with the transfer. There is no bed that's able to accommodate to heights. So while things may be accessible, how truly accessible are they? The other piece that is quite existent is the non-physical barriers, and these are the clinician knowledge gaps and the provider gaps, and oftentimes attitudinal biases. So there is a generalized lack of training by many providers in spinal cord injury in general and in the use of specialized equipment and accessibility pieces. There isn't a lot of interprofessional expertise in spinal cord injury in the greater medical community. There is a perceived deficiency in easily accessible practice tools. And by this I mean it's very easy for a family practitioner to quick look up online what is the latest and greatest for immunizations for the pediatric population, for example, or what are the greatest and latest parameters for blood pressure management. When having someone try to find that information specific for the spinal cord injury population, it can be a bit more difficult. Additional reasons is for better or for worse, some providers find the limited remuneration, so the financial piece in providing care to individuals that may need more time during appointments, a deterrent to providing them care. Because individuals represent such a small number of a physician's practice, there's less incentive to invest time in learning about that patient population, which may dissuade some individuals from providing those folks care. And I suspect there's also a bias against providing care to more challenging patients. And this is not that they are more physically, rather more demanding, but rather it takes more time to see someone with a spinal cord injury and address all of their medical needs in a very comprehensive manner and to feel as though you are providing thorough care rather than seeing 3 individuals with a quick cold that is, you've got a cold, here's an antibiotic, see you later. When we talk about physician familiarity with spinal cord injury, we have to appreciate that SCI remains very uncommon in the general medical practice. And this rarity dampens the knowledge and expertise that's widely available. So there was a very small study performed in Canada on this where they randomly surveyed 15 family practice physicians. The median number of patients per physician, so each physician has a panel of patients for which they're responsible. Average number was about 650. Of these 15 physicians, 5 physicians had no individuals with spinal cord injuries that they worked with. 10 of the physicians had anywhere from 1 to 20 patients with spinal cord injury, but even at 20, that represents less than 3% of their population. So they are not likely going to be very comfortable working with that patient population. All the physicians in that group of 10 reported some level of comfort working with individuals on mental health issues, urinary tract infections, skin concerns, immunizations, and blood pressure monitoring. And I suspect this is because these are the issues that very often come up in the non-SCI population. And really their lowest comfort levels were for managing spasticity, respiratory issues, and autonomic dysreflexia. So really those SCI-specific things. So we have many, many opportunities to improve the preventive care for folks with spinal cord injury. We are now going to do kind of a shift in topic to discuss how do individuals with spinal cord injuries come into the medical system and what are the different avenues that they encounter the medical system. We've got the 911 emergency system. So this is the call 911, ambulance comes and gets you and takes you to the nearest emergency room. We've got the regular emergency room, and by that I mean you getting yourself somehow to the emergency room. Urgent care, we have primary clinics and we have specialty clinics. So when does one go to each of these? For 911, This is really oftentimes the easiest one: choking, not breathing. Someone has a head injury with passing out, fainting, or confusion. If someone has a spinal cord injury, it's probably best served calling 911 and going to the emergency room. Severe electrical burns, chest pain, chest pressures, or seizures that last greater than 3 to 5 minutes. What about going to the regular emergency room? Well, there's a multitude of reasons why one would access to the emergency room: trouble breathing, passing out, pain, very bad headache, sudden inability to move or speak, very heavy bleeding, serious burns, deep burns, allergic reactions, very high fevers, poisoning, seizures, sustained autonomic dysreflexia. And the reason why I highlighted some of these is because even when reviewing these, I had to think to myself, boy, if I had a spinal cord injury, I might hesitate going to the emergency room with this, depending on the circumstance. The passing out or fainting. Many individuals with higher level injuries have hypotension, that they baseline have a very low blood pressure. If someone is lying down for a prolonged period of time and gets up a little bit too quickly, if they pass out for a moment, if they have some Midodrine at home to help with blood pressure support, maybe they do that regularly. So do they need to run into the emergency room for that? I'm not sure. Pressure injuries, pressure wounds can be quite severe, can be quite deep, and can be quite scary. But is going to an emergency room really the best place to get a longer term management plan put in place? Probably not. You're going to want to see someone who's going to be able to look at that wound and develop a longer treatment plan. So this is where it starts getting a little bit fuzzy for folks with spinal cord injuries sometimes about making that decision in the heat of the moment: where should I go? Urgent care. What is an urgent care? Urgent care is nowadays kind of come in lots of different flavors. It's generally where someone goes to with a medical problem that is not life-threatening, but you feel like you can't get in to see your regular provider soon enough. So something like a very bad cold, flu, earache, migraines, a low-grade fever, a small rash that's quite bothersome. Minor injuries, something like a sprain, back pain, minor cuts and burns, or minor broken bone. Once again, I'm writing this and I'm thinking to myself, boy, I don't know if my patient with a spinal cord injury called me and told me I've got a sprain, would I tell them to go to urgent care? I don't know. Or if you know for certain that you were in your chair and you were barefoot and you tweaked your toe going through a doorway and clearly the toe is broken, but you're not getting AD and they're probably just going to buddy tape it in urgent care. Is it really worth going right away, or should you set up an appointment with your primary care provider? So I realized that when it comes to real life, the answer isn't quite always as clear. Primary care provider. Generally, folks see a well-established, meaning that they have a close relationship with their primary care provider. One generally sees their primary care provider for routine follow-up or maintenance issues. Some primary care providers have roll-in or same-day appointments. So sometimes if you have some of those things that might fall into the urgent care category, you might be able to see that addressed. You might be able to see your primary care provider and have them address it that day. It's generally kind of a 9 to 5, Monday through Friday place to go. And medical specialty care, that's where SCI-specific care, physical medicine, and rehab care comes into play. Ideally, folks with spinal cord injuries will be seeing an SCI or rehab specialist at least once a year. SCI physicians are the ones who are best suited to treat things like spasticity, chronic pain, or the various types of pain that can be common with spinal cord injury, equipment concerns, bowel bladder, skin management issues. At times, individuals with spinal cord injuries will see a urologist with some frequency, annually, twice a year, an orthopedic surgeon, and certainly if one has a diagnosis-specific condition, they might be seeing that specialist. So if someone has a history of, for example, breast cancer, they're probably going to be seeing their oncologist with some regularity. Or if they have a heart arrhythmia, funny heart rhythm, they might be hooked up with a cardiologist. So as I mentioned earlier, I realized that life isn't always quite as straightforward as I have condition A, I go to location B. So this is my big disclaimer. These videos are not intended to portray total real life. The actors in these videos do not have spinal cord injuries. They are not orthopedic surgeons. They are not family practitioners. They were my 2 spinal cord injury fellows this year, and they played along with my cockamamie idea to do these videos. And really, the goal of these videos is to serve as an educational tool to highlight some of those issues that may come up in real life and to stimulate discussion this evening. So I'm going to...
Ah! Mary, I just fell off the bed.
Good gracious, dear, what are you doing on the floor? don't know, I was transferring from the wheelchair to the bed and then I fell and I heard a crack.
What do you mean you heard a crack? Where was the crack?
In my legs, somewhere. I think it was in this leg here. I landed awkwardly on my right leg.
Well, does it hurt?
I don't have feeling in my legs.
Okay, you're right. Should we get it checked out at an urgent care?
I don't know what an urgent care is. Do they know anything about spinal cord injury? I don't want to go there and sit in the waiting room and no one knows what to do with me.
Okay, well, what about contacting your spinal cord injury rehab doctor?
I don't really think they work on weekends.
You're right, they're probably on the golf course.
Exactly. So where else can we go? How about the ER?
Well, yeah, let's go to the ER.
The problem with the ER is I don't know if they're going to know what to do with me either. I could wait 2 days and we could wait until Monday and I could go then. But then I know that even if I'm not feeling pain, I may have some spasticity or I may have some autonomic dysreflexia, and we don't have the medication or the supplies to deal with that if it happens all the way through the weekend.
You're right, we better go now instead of wait.
Okay.
All right, so Mike chose to go to the ER, but what are his options in thinking about some of the pieces that were brought up here, it being a Saturday, on the floor, options, where should he go and what are the upsides and downsides of each of the options? You can yell them out loudly and I'll repeat it.
If they go to the emergency room and it's not an emergency, your insurance company charges you a lot.
Right, so
Kept overnight in order to get your benefits.
right, so going to the emergency room oftentimes is very costly unless you have a reason for admission. So that might deter one from going if they feel it's not truly a life-threatening, like you said, emergency. Yes, please.
You should probably call 911. The medics sometimes are a little knowledgeable or can call people who know more what to do.
So sometimes when one calls 911, the medics there have knowledge and they have resources that might be able to get a better answer for you in the heat of the moment. That's also a very good option. Any other options of where they could go? What if we said it was a Tuesday afternoon rather than a Saturday evening? Please.
Called the rehab nurse here. They have a hotline phone number. I called them at like 3 a.m. on a Sunday morning.
So sometimes specialty clinics, although it might be a little bit more time consuming to get into them, they have resource lines or like hotlines that you call in, and if you offer that specific information of this is my condition, they can help triage where you might be able to get your care best. So let's move on to the next step, our next scenario.
Well, hello, Mike. I hear you have a broken bone.
That's what I've been told.
Is that right? Well, I'm Dr. Fix-A-Bone, so I'm here to help you. I love fixing bones. So tell me, what's going on?
I fell, I heard a crack, and now someone told me that my leg is broken. So is it?
Well, yeah, on the x-ray it looks broken, but you don't walk, so we don't need to fix it.
Are you sure I don't need to fix it? I still use my legs to transfer.
Huh. That's interesting. I didn't think about that. All right, well, maybe we could just cast it up and make sure it's all straight.
Doctor, how can I wear a cast? Because I need to check my skin every day. I don't have any feeling in my legs. So what would I do with a cast on my leg?
Well, there is going to be a lot of swelling, so that's another thing. Huh. But are you questioning me as a doctor?
Well, I'm just bringing up some things related to my injury. I have a spinal cord injury, and there's a few things that are different with us that I want you to just be aware of. So I'm just wanted to tell you.
So tell me your worries.
So one of my worries is I need to be able to transfer, and if my leg is in a cast and it's sticking out, I'm not going to be able to transfer. It's going to be like a battery ram. It's going to hit everything when I'm trying to do anything, and I live in a kind of small house. I don't have space enough for my leg to be swinging around everywhere. And then on top of that, my leg doesn't even go out fully because it spasms every time I try and make it straight. So I don't even know how you're going to be able to get it into a cast in the first place.
Well, that's a good point. I guess we could consider surgery as well.
Okay, there's some other things as well, not just the transfer. When I need to take care of my bladder,
Wait,
how am I going to do that?
I don't fix bladders. You gotta go see a bladder doctor. All I do is the bones.
Well, it's not my bladder's broken or it needs fixing. I have a spinal cord injury, so it doesn't work properly, which means I have to catheterize myself every 4 to 6 hours. And how am I going to do that with my leg in a cast?
That sounds like a question for a bladder doctor.
And it's not just my bladder doctor, Dr. Fix-It. It's my bowel as well. How am I going to do my bowel care?
That sounds like a general surgery problem.
So, what were the challenging parts of this interaction? What were the cringeworthy parts? Please.
The physicians seem really arrogant and seemed like they knew how to fix the situation. And then the patient was trying to explain, hey, this doesn't work for me. I have all these conditions dealing with SCI. And the doctor just didn't seem very sympathetic at all.
So the physician seemed quite arrogant and seemed to feel as though he knew all the answers when the patient was trying to give information that was specific to his needs and how he would best be served, and there seemed to be quite a disconnect there. What else was cringeworthy? Please.
And the doctor's just complete lack of comprehension of what the patient's daily life consists of. You know, transferring and all that kind of stuff, and just this wall that just could not be penetrated.
So a lack of appreciation what that individual does on a daily basis, kind of activities of daily living, mobility, the idea of transfers being a bit different, the idea of self-care as being a bit different, most certainly. Were there any positive aspects?
The doctor didn't just barge ahead with what they had, they stopped. The doctor stopped and didn't say, well, I'm doing this, period.
So the doctor did at least say, that's a good point, and didn't barge ahead regardless. So there may have been some consideration when the patient brought up some points of, oh, I didn't think about that. Oh, I didn't think about that either. Although he didn't seem to fully embrace the idea of, I need to deal with the entire individual and the medical condition, how it interplays with the other piece. He was very focused on, there is broken bone, we need to address broken bone, and he didn't seem to appreciate the fact that, yes, broken bone is there, but we've also got to deal with how is broken bone going to play along with the bladder and the bowel and the skin and all those pieces. Please.
At least she knew where to direct the patient to, like a urologist, or a skincare wound or something like that.
That is true, that he at least was confident in his lack of knowledge in some of the other organ systems and offered direction.
It was
oh,
she.
sorry, she.
Come on.
I was a she, and we were intentional with making sure that the surgeon was a she in this case. Let us move on to our last vignette.
Well, hi, Mike. I heard that you broke your leg.
Yep, I went to the ER and there was a doctor in there and yeah, he told me I broke my leg.
I heard you had quite the conversation with Dr. Fix.
Well, I wasn't trying to be rude. I wasn't trying to tell him how to do his job, but I just wanted him to know that I have a spinal cord injury and he needs to consider lots of different things. And so we had a bit of a conversation.
Well, I think that's great. A lot of doctors in training, unless they're trained specifically in spinal cord injury or rehab, sometimes don't know a lot of this things that come along with having a spinal cord injury. So I think it's really important that you bring up, you've taught me a lot about spinal cord injury. You taught me about your skin and watching that and your managing your bowels and bladder.
Yeah, a lot of that I learned in inpatient rehab after I had my injury. So.
All right, well, let's take a look at the leg here. How's it doing?
It's okay. It's in a immobilizer right now, but the spasms kick in sometimes with it, and so could be better, obviously.
Speaking of spasms, last time you were in here, we checked a urinalysis, and I gave you some antibiotics. I was hoping to check that again and just make sure that the infection is cleared.
Oh, well, after about 2 days on the antibiotics, I started to feel like much better. My spasms reduced, I wasn't having any more fevers, even my urine started to look a little bit better. I completed the course of antibiotics and I feel great now, so I don't think I need to check my urine at the moment.
Yeah, I would feel more comfortable if we did, just to make sure that it cleared that infection.
You know, before you were telling me about how I've taught you a lot, is it okay if we maybe talk about a few other things?
Yeah, absolutely.
So when I was in inpatient rehab, they did tell me that my urine's always going to have some bacteria in it because I'm catheterizing myself, and so I'm always going to have that there. And so I'm sure if you check a urine study, it's probably going to show I have some bacteria, but I feel completely fine now. I don't have any symptoms. I had the antibiotics, and I don't want to take medication if I don't need to take it.
Well, you're right. Using catheters means that you will likely have some bacteria when I check it. And you're also right that if I give you antibiotics when you don't have an infection, you're at risk for having resistance to that antibiotics. And there are other side effects that can come with taking antibiotics, including a C. diff infection, which is a gut infection.
Yeah, I had that before. I had that about a year ago, and it was the worst thing that I've probably had. It was really bad.
Well, I would really like to check your urine, if that's okay.
Doctor, I don't think checking my urine is going to give you anything other than increasing my chance of getting resistance.
All right.
There is some resources though. If obviously I'm telling you, and I learned it from other people, and so there's resources that we can use that are available online. I think they told me when I left rehab that all of this information is online, and if it ever came up with another doctor, they can always look it up. So if it's okay with you, maybe you can check on some of those resources, and then if you're finding it on those resources that we need to check, then we can check. But
well, great. I'm going to review the spinal cord injury guidelines for treating urinary tract infections, and then let's touch base after I do that.
That sounds great. Thanks for listening.
All right. So what in this instance went a little bit better?
More personal, they know each other because that's the regular practitioner that he goes to.
They were more, the physician was more personal. It was clear that they had a well-established relationship.
Yeah,
exactly.
And they had a good communication.
Good communication. Please.
I think in both videos, the biggest positive for me is how well the patient is advocating for himself, for his needs.
So one of the
He's not afraid
positives
to
is
speak
how well,
up.
oh, sorry?
Oh, he's just not afraid to speak up and make sure that he's clear.
So in both situations, the patient was very vocal about advocating for his needs and was not stepping down from saying what he felt was going to be best for him. Please.
The video was shot in an outpatient clinic in the hospital.
Yes, indeed.
It was not shot in a primary care doc's office, which has exam tables that are too high, too short, and immovable.
You are mostly correct, and by that I mean it was shot in an SCI primary care clinic. So it was primary care, but it is SCI specific, so you're right. The tables that we use are totally adjustable, and you are 100% spot on. For most primary care clinics do not have adjustable tables. So that scene where he's sitting very comfortably balanced on a very low bed is most likely not going to happen in a primary care clinic. You are right. That's all I had though for videotaping. What could have been better in the scenario? Please.
Well, he made a very good case not to do the urinalysis. I think the doctor should have been a little more persistent because it's possible to differentiate between different types of bacteria, and it would have been a minor test that probably would have been beneficial to him to know whether or not he had any further signs.
So the patient was quite persistent in his desire not to have the urinalysis, and the physician was quite persistent that she wanted it. So there was clearly some tension there still, and that it may have gone both ways, that perhaps he should have had that done, and that his more aggressive, in a positive way, advocating for himself may have been to his detriment. So I think that tension oftentimes does happen in the primary care clinics. So having the courage to speak up to a non-SCI provider or an SCI provider, I think for individuals can be challenging as patients. And finding the right words, particularly in the heat of the moment, can oftentimes be difficult. So having kind of some prepared language or verbiage to be able to offer. So saying something like, you know, I know SCI is pretty rare. Something I was told by my SCI rehab team was ABC. Or coming back to that, I've been encouraged to remind all my providers that ABC. This oftentimes comes up with skin, because I think that skin and neurogenic skin is not appreciated as well. Or I learned in rehab that it's really important. And then there's always the fallback of my SCI doctor told me ABC. So what are other things that you all have had to use, or when you were trying to advocate for yourself in an instance where you were pretty certain that something was not going to work as well for you? How are ways that you tried to bring that up with your provider? Please.
Just reminding them that there are other, aspects to your body. I mean, I one time got thrown out of my chair and went to the ER, and they, I said my neck was sore, and they checked that out, and then I left, and I thought, God, they didn't even check my legs. They, pretty much didn't look at anything that I couldn't feel.
So kind of reminding providers that one condition may be interrelated to many other organ systems. Exactly, that when one with a spinal cord injury comes in with a very specific concern, many providers may not appreciate that while that one specific concern may involve that one organ system, that plays a role in many other pieces. And I always think of the example of someone with a fracture, with a paraplegia or with a tetraplegia, because that to me really demonstrates how all those organ systems come into play. So if someone has a fracture, you've got skin issues that come into play. You're going to have to manage bowel and bladder potentially differently. You have the autonomic dysreflexia risk. You have potential respiratory risk if someone's going to be on bed rest for a prolonged period of time. You have the functional aspects. So yes, it is a broken bone that perhaps an orthopedic surgeon will address, but there are so many other organ systems that have to be addressed in that setting in order for that person to maintain and maximize their function in that immediate setting and maintain it over the long run. And I think that piece is sometimes unrecognized by many providers who aren't as familiar with working with folks with spinal cord injury. So different strategies that actually all of us can use when working with our providers is, one, come prepared to the appointments. Write down a list of questions and concerns before the appointment so that you are going in with a very clear agenda, and you can make sure that those things that you've been wondering about at home are going to be addressed. The other piece is that oftentimes a lot of information is provided at appointments. So consider bringing a close friend or a family member just so you can have 4 ears rather than just 2 ears collecting the information. Take notes or have a friend or family member take notes during the interaction. Many medical systems are now moving to allowing patients access to their medical records, so learn how to do that. That's a good way to be able to go back to your chart, take a look at the physician's note, and see the points that they had highlighted in case you had forgotten exactly how you were supposed to do that medication wean, for example. And then lastly, ask your provider for their contact information and what is the best way to communicate with them. Are they someone who would like you to call their clinic and work through their clinic manager or their nurse? Are they someone who has direct access email and you can communicate to them that way? Or are they a voice message type of person? Kind of SCI-specific communication strategies, it is always helpful to have a pre-printed list of medications and a problem list. And with medications, name of the medication, the numerical dose of the medication, and the frequency. So baclofen, 10 milligrams, 4 times a day. Telling your provider sometimes, I take 2 tablets twice a day can be challenging if you don't know the exact dose of the tablet and the provider's trying to adjust it, increasing it or decreasing it. So having that exact numerical value can be very helpful. A problem list is a list of diagnoses that go along with your entire person. Oftentimes with spinal cord injury, that'll look like something like T6 spinal cord injury sustained in motor vehicle accident in 1992. Surgical fixation included fusion from T2 to T10, bladder managed with the Foley catheter, bowel managed with daily bowel care, spasticity, history of pneumonia, for example. Next is do not assume SCI knowledge by your provider. I think we highlighted that today with some of the vignettes. Be very specific with your SCI activities and abilities, particularly when using words and language that may be very familiar to you or your SCI provider, may be completely foreign to other providers. So saying, I do a bowel program, will oftentimes mean very little to someone. And telling your provider, my bowel program consists of me getting assistance with a transfer to a commode chair, an insertion of a suppository, and digital stimulation, then transfer back, that can be more helpful than just saying bowel program. Also, when discussing caregiver issues, if you do happen to have a wound, for example, and the provider that you're working with has said, well, let's do 3 times a day dressing changes, they may not appreciate that you have a caregiver coming in maybe once a day, and that 3 times a dressing change isn't going to work very well for you. So being clear on, I have someone come in the morning to help me get dressed and mobilized and bathed, and I do it in the evening myself, so 3 times a day isn't going to work that well for me. Ask questions. Offer SCI resources, online resources, or contact to a rehabilitation provider, and really be prepared to work collaboratively with the provider. When we look at resources, there are some fantastic, fantastic resources available online. So this organization, Northwest Regional SCI System, has a fantastic website that is chock full of different pieces of information, not only for folks with spinal cord injury, the consumer population, but also resources for clinicians. The Spinal Cord Injury Research Evidence Project is based out of Canada. PVA, Paralyzed Veterans of America, puts out clinical practice guidelines. There are 2 flavors of those guidelines. There's the consumer version of the guidelines, and there are clinician versions of those guidelines. And those guidelines are really some of the strongest pieces that we have as clinicians in providing guidelines for some key topics in SCI medicine. Christopher and Dana Reeve Foundation, University of Alabama, the last 2, Caring for Persons with Spinal Cord Injury and Actionable Nuggets, are coming out from Canada. So there are key resources that are out there. And really, you folks with spinal cord injuries and caregivers and friends and support groups should know at least one of these keywords, so that if you find yourself in a situation, you feel that you have the tools to say, you know what, Doc, could you please take a look at this website to remind yourself of some of the issues with neurogenic bladder, for example. This is a snapshot of this program's, one of the portions of this program's website, the Empowerment Project. On this site, there are resources of accessible, downloadable pieces of information on one's health summary or discharge care guidelines or health guides for clinicians. There are folks out there who are working on some more creative solutions. So using some of the technology that we have available to us today, such as e-medicine, group in Canada is developing a patient-centered teamlet of an SCI physician, nurse, social worker that is available by virtual consultation. So this is kind of like the SCI on-call team. And given that Canada is quite large and many areas are quite rural, this has been a good system for them. There are also a number of groups developing primary care toolkits, so small, downloadable, in-the-minute resources for a primary care provider to go to and pull up a sheet of paper that says, okay, I'm working with this individual with a spinal cord injury. I need to highlight bowel, bladder, skin, autonomic dysreflexia, similar to guidelines that they have available to them for immunizations for the pediatric population, for example. This is a snapshot from this organization's personal health summary that they use. This is something that a provider could download and insert into the medical record so that when they're doing that primary care encounter, for example, they know that they've hit all those key topics. So I'm hopeful that we have kind of identified some of the strengths and some of the challenges in decision making in identifying a setting that one with spinal cord injury should access with different concerns. I think that we all recognize that many providers may not be as familiar with your specific SCI needs, and I'm hoping that you are all empowered in sharing your knowledge and that I've offered you some resources that you can use with your providers and communicating with them. Many thanks. Carolyn Campbell was one of my spinal cord injury fellows this year. She was Mary or Honey, Dr. Fixit, and Dr. Carolot. She is going to be joining us at VA Seattle as an SCI physician. Dr. Hardeep Kainth is my other SCI fellow. He was Mike in the video. He is going to be going up to Edmonton and working with the team up there as an SCI physician. Dr. Steve Burns is one of my colleagues. He's also my boss and my videographer for the video, so many thanks to him. And this team here, the SCI Forum team, was fabulous in taking my wacko idea and helping me develop a presentation today. So, and thank you all for your contribution and having the dialogue with me.
We have time for questions, comments.
Okay, when it comes to communicating to a non-SCI physician about a SCI issue, let's say that you're that physician and I'm trying to explain to you about autonomic dysreflexia. You're used to treating people who have sensation, and you say, give me a shot, and you notice I didn't react. And you say, oh, you didn't feel that. And I say, no, and you go, oh, that's good. And I say, well, not necessarily.
Right.
And then it can lead to pain below the level of injury.
Yes.
Can lead to autonomic dysreflexia, and then you go, well, what's that? Well, that's high blood pressure with possible very serious consequences. How would I communicate that to you in that setting?
I think specifically with autonomic dysreflexia, I think that as a non-medical individual, trying to explain what is happening pathophysiologically, which is kind of the language that the physician is going to most understand, is going to be difficult because you as the individual with a spinal cord injury doesn't have that pathophysiologic language. So I think that's one of the instances where having an AD card, and I encourage anyone who is at risk of autonomic dysreflexia to have a pocket card that it says, I'm at risk for AD, this is what it is, and this is how it's treated. And that's also one that I think is very helpful to be able to direct someone to a website of, please go to this website, go to the PVA website, and pull up the clinical practice guideline on AD, because that's where the physician who is most familiar with that hardcore medical pathophysiologic language can pull up the picture and be like, oh, this is autonomic nervous system, these are the pathways, this is why this individual is saying they didn't feel the injection, but their blood pressure is going up. And I think that with AD, having that visual and having that medical verbiage is very, very helpful, because it's hard for you without having that, well, you've got this injury and you've got the sympathetic response, and that if you don't have that language, they're going to be like, what are you talking about? Your blood pressure goes up. You know, your blood pressure is 90 right now, and now you're telling me it's going to go up? Well, what are you talking about? But the AD card, print one out. I'm happy to give you, I can show you where you can get one. I'm happy to give you one. Fabulous. Photocopies, every pocket.
Just to piggyback on that, you know, I had to call 911 for someone who had an AD response, and the EMT didn't really know about it at all.
Yeah.
And I was trying to explain it to them, and I'm very wordy and not good at communicating. And so eventually I just gave them that card. And I've heard this experience with like multiple people calling 911. So maybe I was just trying to reinforce that is really good, because even to the EMTs, in an emergency situation, they might not be aware of it.
No, I think it's funny for those of us who live in the spinal cord injury world in one format or another, something that is so basic for us where we think AD, and while everyone knows about AD, it is not discussed pretty much ever in medical training unless you're in SCI medicine or you're in physical med and rehab. It's a topic that may come up in one lecture in medical school and maybe an exam like right after that lecture. It's not ever discussed. It's kind of this funky, neat phenomena that happens in these folks with spinal cord injury. And unless you encounter folks with spinal cord injury, you never see it. But for those of you who have spinal cord injury, it can be such a critical piece to your care. So you're right that, that folks don't know about it. Medical folks don't know about it. EMT folks don't know about it. Unless you live and breathe spinal cord injury medicine, you're not going to know about it.
I have a question.
Please.
About the broken leg, I've heard of people dealing with that, and what is the actual, what is the medical recommendation? Because those are a lot of complicated issues.
They are totally complicated issues, and there's not one correct way to manage fractures. It really depends on the location of the fracture, the type of fracture, the individual's ability, how are they using their limb. I think historically, and we're going back, a few decades, people tended to conservatively heal fractures more often, but I think that surgical techniques are getting more advanced, and I think people are appreciating that improper alignment of a fracture is not acceptable, that we seem to be using surgical interventions more often in a positive way. By that I mean I think historically there was an idea of you don't walk, so it doesn't matter what position the leg heals in. And we have very clearly seen that that's not acceptable, because if a leg heals improperly and it's at a much different angle, for example, than it was prior, that's going to affect how someone interacts with their chair. So if they are much wider now because their leg is sticking out, that's not an okay thing. So I think that things are shifting, and there's so many different factors that come into play that it really is best to have a very clear dialogue with the surgeon who might be proposing one mean or another, the individual who has the fracture, and ideally a rehab doc right there on board. I always find those interactions with our orthopedic surgeons kind of very enlightening, of hearing them, what their thought process is, and then the individual with the spinal cord injury and me saying, well, did you think about this? And no, well, and at times we've both agreed, all three of us have agreed on what the proper course of treatment should be, and other times there's been some conflict, and we've had to go one way or another for better or for worse.
Can I just highlight one of the things you said
Please.
in terms of the conversation that you have with the physician? I think whenever you're trying to give somebody advice, I think it's really helpful to just simply ask for permission. Can I tell you, may I tell you something that I learned? I mean, starting with that kind of asking for permission can really help diffuse a situation that would be otherwise maybe more fraught, and can often make the person more open to hearing the feedback if you simply ask for permission. So that's a good trick that you put up there.
Oh, you're right. All right. Great. Thank you, everyone.